entirely different topic. It's on treating inflammation in dry eye, and our speaker is Dr. Ananth, DoddaramegoudaD1 from Lotus Eye Hospital in Coimbatore. He's a prolific phaco surgeon and anterior segment surgeon. And let's listen to him, and then we can have a discussion on all the topics.
So good morning, Lotus Eye Hospital, Coimbatore. I'll be treating on how to treat inflammation in dry eye. At the outset, I would like to thank Dr. Srini and Alavan for giving me this. These are my financial disclosures. Whenever a dry eye topic comes on the podium, whether at national or international podiums, I can always see the crowd is of two varieties. Some people think dry eye itself is very, very complex. There is huge amount of theory involved. There is so much amount of molecular diagnostic involved. Why should I bother? I can treat it simply with drugs. And there are other group who thinks that I can treat with CMC. If not CMC, I'll go with HPMC. If not HPMC, should eliminate. So to make the group active, any young crowd here, I can just ask one or two questions. Hello? Hello? Just to make this dry eye topic attractive, not to bore you, let me ask you one or two questions, please. So can any youngster or PG tell from where this possible bits are secreted in the tear film? Where does it come from? What's the source? Any PG? I'll make you attractive. I'll make you active for another next 10 minutes. Just 4 questions I'll ask you. What does your textbook says? Where does this possible bit come from? Anyone? Louder. Yeah, everyone thinks that it's from meibomian gland. All the polar, non-polar comes from meibomian gland except for possible bits. It comes from the ocular epithelial cells. Okay? Second question, I will make you active. How many nerve endings are there per square millimeter in the cornea? Can anyone think? It's almost 7,000. Okay? Then where do you get a condition where you get pain in the eye but there is no stain? We call it as phantom cornea, post-LASIK patients. All LASIK surgeons are worried. This patient keep on coming with pain, but there's nothing what to do. That's phantom cornea. Where do you get strain without stain? You have eye strain, but there's no stain. But still patients come back to you. That is called as decreased wettability. I think all are active. I'll proceed with my topic. So before I go into my inflammation, let us have into dry eye review. We all know that used to study. Dry eye is a multifactorial disease. There are 3 things involved. There is a tear film instability, there is change in osmolarity, and there is inflammation. These are the 3 things. This whole slide describes the vicious cycle of the dry eye. And as I said, it is multifactorial. There are multiple intrinsic and extrinsic factors. Tear film instability, we classify it into aqueous deficiency, we divide into increased evaporation, and the third variety is decreased wettability. Whenever there is aqueous deficiency, we diagnose with help of shimmers. Whenever there is increased evaporation, we understand by doing the TPET. And the decreased wettability, what I told, that stain, only no stain, no minimal reduction in the TPET. If you look to the symptoms of aqueous or evaporative deficiency, almost everything looks similar. But when you give minute importance to the symptoms, there is a major difference in the symptomatology of this. What are the ortho tests we do? Any ophthalmologist will do. We have our own ocular surface index score. We do examine the face, slit lamp examination, we do tear film breakup time, and we do the staining and shimmers 2 test. Inflammatory marker is not yet available easily, and the patient even can't afford in our country. So before doing shimmers, always TPET has to be done, because whenever we apply the shimmer strip, we don't want the epithelium to damage. That will not give us a correct TPET value. So TPET breakup time, you know how to do. We are installing the fluorescent there. More than 10 seconds, the values are normal. Anything less than that is significant. These days, lot many topographers have come up with non-invasive TPET. Topographers and IOL masters, so non-invasive technique also can be done. Shimmer test, it is done to detect the aqueous. So more than 15 is considered as normal. Anything less than 15 is abnormal. So this is how we do. Coming on to osmolarity, our tear film osmolarity should not become hyperosmolar. Any values changing more than 308 or difference of 8 between both eyes, it makes that tear film hyperosmolar. Any hyperosmolarity of our tear film will bring about 3 changes you need to understand. It brings about reduction in the epithelial glycogen, there is a goblet cell damage and the goblet cell density reduces. When all these pathological changes happens, it gives us unstable tear film and there is reduction in the mucin and we start getting our tears evaporating. So, Allergan also comes up with osmoprotective agents in terms of optive to protect the surface. Now coming on to my topic as such, the inflammation. So most of the times this is one thing that is usually forgotten, that never comes on to the mind of the ophthalmologist. We need to understand whenever the vicious cycle goes from instability to hyperosmotic to inflammation, there we start getting a tissue destruction or a neurosecretory block. All these episodes of neurosecretory block in turn leads to the reduced reflex secretion, the drive to the lacrimal gland is completely reduced, and all this happens because of the release of mediators or chemical mediators. We are able to assess these levels which clinically correlate with the severity of the dry eye disease. And this is a C cell mediated damage. Whenever T cell mediated activation happens, we get the influx of this calcium into the cells, this calcium bounds to the column, then the NF80 is getting dephosphorylated, there is complete transcription of the gene which is involved in the immune system. Because of all this T cell activation, we start getting all these sorts of pathological changes. The most important is there is promotion of apoptosis, release of multiple growth factors, which brings about the neurosecretory block. Amongst these, the most important is MMP9. MMP9. This can also be diagnosed with the chips which are available in the market as of now. So if you look into this slide, you will understand the difference between the LTI and the dry eye. As I mentioned, the multiple neural mediators, what and all to be named, are able to be identified in the dry eye disease patients. The only thing which gets reduced is the goblet cell density. Goblet cell density reduces, the rest of all the mediators are increased in the dry eye disease patients. How to diagnose this sort of patients? Initially, patient comes with a dry eye complaint, but whenever patient starts complaining of the photophobic symptoms, then you start getting congestion, we do start suspecting the inflammation. There is a typical complaint that where patients do complain that there is increased watering whenever they get exposed to AC or humid conditions and whenever there is prolonged screen time. This gives us a clinical clue that whether it's in the face of inflammation. Again, the other clue is you are treating among the patients with initial aqueous substitutes, but the patient is still not responding. The most important thing as mentioned is remember tearing, photophobia and blepharospasm. This gives a clue that the tear film has gone into phase of inflammation. The order of test what I mentioned should be repeated again, which gives us a clue. Staining plays important role. MMP as I mentioned. So how do we treat it? We treat with the ocular substituents. When we come to the management of inflammation, the first thing which comes onto our mind is steroids. But the steroids have a limited role. Fluoromethalone or loteprednol, we can't use for long-term usage because it has got its own adverse effects. And doxycycline, what we use, it works very well for the patients whenever patient is having a dry eye because of acne or blepharitis. And omega-3 fatty acids, even though it's immune modulator, efficacy is not so good. So we need to depend upon cyclosporin. So cyclosporin is one of the FDA approved drugs. It's available in the market since long time. Other than the one which basically bought out is it's a cationic oil-based ophthalmic suspension, which is around 0.05%. See the modulator of the action. It inhibits cell activation. It inhibits leukocyte migration. The most important is it has got anti-apoptotic activity also. Because of this property, this becomes the preferred choice to control inflammation in patients suffering from the dry eye. How does it work? It binds to cyclophilin, the cycloneurin which is not getting activated, so the T cells, they can't proliferate. Finally, there is a complete immunosuppression. But clinically, what do we want? We want the improvement in the symptomatology of the dry eye. How do we do it? We need to have the patients, whenever we put the patients on cyclosporin, there should be improvement in the Schimmer score, which is evident from the literature as well as from our personal experiences. And even the TPET time, when the patients are on cyclosporin for 6 months, we can see a significant improvement in the TPET score too. But most of the times, the question is how long we can continue cyclosporine, maximum till 6 months. But there are experiences, and even my personal experience, I do continue cyclosporine for 1 to 2 years also. Post 6 months, if the patient is tolerating the cyclosporine well, we can do continue. If the symptoms are improved, we can stop the cyclosporine, shift him on to steroids. If there is acute or subacute flare of inflammation, then again we can resubstitute to cyclosporine. So it is safe for long-term usage also. With the use of cyclosporine, the unnecessary use of other drugs to treat the dry eye is also been reduced. It's a twice daily drug. And the mechanism of action is, as I mentioned, it starts after 4 weeks. So until 4 weeks, the patient has to be on fluoromethanol. These are all the indications what I mentioned. The most important, it also increases the goblet cell density. There is one important study. Since it is a lipophilic drug, burning sensation has been the side effect. There are few subsegment of patients who stop this drug post 6 months. So here there was a study done where doctor himself counseled the patients, giving the risk-benefit ratio, considering the dry eye symptoms and the burning sensation of the cyclosporine itself. When the patients again reinitiated to take up the cyclosporine, and it was continued for 1 to 2 years, and they felt better with the dry eye symptoms. So to conclude, inflammation is one of the mechanisms, and cyclosporine is one of the most important anti-inflammatory drug for the patients suffering from dry eye. Thank you.
Patient comes with symptoms and signs of dry eye disease. So you told us that it could be reduced aqueous production or evaporation and inflammation and all that. So how would you go about excluding them one by one? What
Yes.
would be your
As I told, it's a multifactorial disease. The first and foremost symptom is, these days, the dryness complaint has been vaguely described by everyone. Even a small complaint can be a dryness, that's what the patient tells us. But whenever a patient comes to us with the symptoms, we need to give importance to the history, how long he is suffering, occupation, age, or is he on any other medications, topical or systemic wise. The basic slit lamp examination has to be done, starting with the T-bed, then with the shimmers and the questionnaire. If you feel the shimmers has been very less, I just go with carboxymethylcellulose with lifestyle modifications. If there is the complaints regarding with the stability, we go with the lipid-based molecules to stabilize the tear film. If the staining pattern is very significant, if there is a history of post-LASIK or post-cataract surgery, post-LASIK means I go with osmoprotectants. If it is cataract surgery, I just go with any CMC molecule with an antioxidant property such as trehalose or sodium alanine. If whatever the signs of inflammation I mentioned, I would like to start them down, cyclosporine.
So, just one more question. Between the various types of artificial teardrops that are available, can you just educate us on what would be the main categories of
Categories.
and how would you choose them?
Carboxymethylcellulose, hydroxypropylmethylcellulose, then comes the sorbitol groups, the PPG groups, sodium alanine. These are the 4 important things which I personally consider. All it's based upon the physical and the shear properties of these molecules. It's all about the stabilizing effect, the neutralizing effect, and the retention time. If at all, if CMC and hydroxypropylmethyl retention time is better, so they have to be used more frequently, 4 to 6 times. Sodium alanine and PPG groups, since they're PPG is sorbital group, retention time is slightly better, 3 or 4 times, based upon the patient's occupation or based upon the complaints, we can choose. Trehalose component has got some amount of antioxidant property, so it can be chosen for the patients where there are epithelial defects or small amount of staining pattern without any inflammation.
And this HP core and things like that, just to increase the retention time.
Yeah, just to increase the retention time. This sorbital group always just to increase the retention time. They are much more like a stabilizing agents.
Are there any questions or comments?